Hi, my name is Dr. Julie Philley. I'm a pulmonologist and NTM lung expert at the University of Texas Health Science Center at Tyler, and I'd like to pass it over to my friend and colleague, Dr. Keira Cohen.
Hi, everybody. My name is Dr. Keira Cohen. I'm also a pulmonologist and critical care doctor at Johns Hopkins, where I'm the director of the Center for Nontuberculous Mycobacteria and Bronchiectasis.
We're glad to be with you today, and I think it's important that we actually go over some of the goals of treatment and some of the medications and other various nuances that we use in the treatment of non-tuberculous mycobacterial lung disease. We've learned some things since the prior guidelines, and that is, first of all, that the natural history of non-tuberculous mycobacterial lung disease can vary from individual to individual. It can be unpredictable, but what we do understand is that many of these patients progress. Dr. Cohen, can you comment a little bit about the watchful waiting aspects of treating this disease?
So, absolutely. The current 2020 guidelines recommend that if you have a patient who meets criteria for NTM lung disease, that rather than watchful waiting, we should instead initiate therapy on patients. And this is particularly true in patients who have risk factors for progression. And important risk factors that portend a poor outcome and where patients are more likely to progress are those who have a high mycobacterial burden in their sputum, as evidenced by an AFB positive smear, or a radiographic pattern that includes a cavity.
It seems to me, and in my practice, I see this often, that patients with worsening radiographs and worsening symptoms, those are the easy ones to go ahead and initiate treatment. And most of us around the country would recommend that you go ahead and start. But there are some areas where observation is probably okay. Some of those would include very mild symptoms with very mild burden of disease. So those patients that just say, I feel great and I don't understand why we're even talking about treatment. Sometimes we'll watch and we'll wait. We also understand that there's some factors for waiting in patients that are not motivated, but also in organisms that are more difficult to treat and the toxicities are higher. Sometimes that includes organisms like Mycobacterium abscessus. Dr. Cohen, do you want to comment on when treatment, you mentioned this a little bit, but when treatment is absolutely necessary?
Yeah. So we recommend initiating treatment on people who would have a poor prognosis if we didn't start treatment. And those include people who have poor nutritional status with a low body mass index or a low albumin, people who have elevated inflammatory markers, which may suggest that this infection is not quiescent in them, but is instead causing problems. And similarly, I'd mentioned before, cavitation on chest CT scan is another reason why we may wish to start treatment. In contrast to organisms that may be more difficult to treat, if you have a mycobacterial species that has a more favorable outcome, then there is a greater benefit to starting treatment, such as for Mycobacterium kansasii, which usually has an excellent treatment response. Other reasons we may want to start treatment is a more vulnerable host, such as one who has concomitant immunosuppression or is on immunosuppressing meds. And lastly, for patients that are very symptomatic, they may derive more of a benefit of starting treatment. And for those patients, we would want to initiate therapy sooner rather than later.